Hello and welcome back to the podcast. My name is James Waldron, GP and GPnotebook educator and podcaster. And this is part 2 in our 4-part series shining a light on HIV in primary care. And today we're focusing on a really important question: what happens next after a positive test result? And how can we support better health in people living with HIV? Now, if you missed part 1, do go back and give it a listen when you have a moment. We covered a lot, from tackling stigma to making HIV testing more routine part of our consultations, especially in general practice and A&E. The takeaway: the earlier that we test, the earlier we can treat, and that makes all the difference to long-term outcomes. So on to today's episode, and I'm really pleased to be able to welcome back our guests from part 1. And we have Dr Grace Bottoni, Lewisham GP and HIV and Hepatitis champion, and Dr Mel Rosenvinge, consultant HIV specialist, also based in Lewisham.
Hi, thanks again for having us.
Hi, thank you for having us.
Welcome back, both of you. It's so great to have you with us again. Well, we packed quite a bit into the last episode, so if you're just joining us now, it's definitely worth going back to catch up afterwards. But today we're moving this conversation forwards. So, you've made that diagnosis, you've got that positive test result in primary care, so what next? So, Grace, I'm going to come to you first. And as a GP, you've got that result in front of you. What are the next steps?
Well, yes, exactly. So we're talking about, trying to increase testing, but I think a lot of people do worry, oh, what happens if I get a positive result? Because not that many people have had to deal with that in primary care, or some people have only ever had to deal with a couple in their sort of career. So I think you're quite right in being worried about what to do. But I think, um, you just have to um, well, first of all, don't panic when you get a positive result, and just treat it like you would when you're, trying to break some difficult news to a patient. So make sure that you, if you can, speak to the patient face to face and arrange an appointment. Make sure you've got enough time to speak to them. And if you can speak to the HIV clinic before seeing the patient, I think that's even better, just because I think it'd be good to know what your local pathways are like. So, for example, where I work, um, GPs don't have to do a confirmatory HIV test. It's actually the HIV clinic that does that when the patient attends. But that might be different across, well, different in your area. So speak to your HIV team, find out if they need a confirmatory test, and also if they offer any support for patients, like peer support or counselling, um, and whether they're able to offer an appointment quickly for that patient, so that so that you can, when you do meet that patient, you'll be sort of armed with all the right information that you're able to give them there and then. And I guess what we also want to try and do is reframe the fact that receiving an HIV diagnosis is a death sentence, because we know that that is no longer the case. As we've talked previously in our podcasts, people who are living with HIV, if they are taking their medications correctly, they they cannot pass on HIV, and they can lead a very healthy life. And yeah, and so we need to try and reframe this.
Mm. And I think reframing that conversation is so important. I mean, this is a difficult conversation. Of course, it's difficult to give patients news such as this, but actually, at that very outset, giving people, I suppose, the positive information that when this is treated, people can do very, very well is so important. And I think getting the HIV clinic involved nice and early, especially to help upskill and educate you as a GP, I think it's a great idea too. So Mel, when they contact the HIV clinic, what are we looking at then? What might happen at that point?
Well, obviously depends on where you're working, but most centres do try and see anyone with a new diagnosis within a week, and hopefully they might even be able to offer them an appointment the same day or the following day. And when they come into clinic, we generally tend to get them to see one of our clinical nurse specialists who perhaps has a bit more time, and we'll just sit and listen to them and listen to their worries, because it's about addressing those. Because I have to say, giving some people a reactive HIV result. It can be quite straightforward if they're from a community where there's perhaps quite a bit of HIV and they've got friends who are very well controlled on HIV. They take that on board very differently to someone perhaps who is from a community where there's an awful lot of stigma against HIV. And a lot of what we do in those first sessions is kind of myth busting, basically. And just reassuring people that they can have children, that they can do whatever job that they want to do, but they do need to come and see us regularly and take their medications regularly. It's quite nice to talk about, there are even injections now for HIV treatment. It's not even just tablets. These are all really positive things. There is one thing that we do need to address quite quickly, and I mean, it's brilliant if the GPs were able to do that, and that is if they've got any current sexual partners, because obviously if you have unprotected sex with somebody and you're HIV positive and you're not on treatment, you might transmit the virus to that person. And if they've had unprotected sex in the previous 72 hours, then their partner might be eligible to get PEP, which is post-exposure prophylaxis, which they can take for a month, and they can get, they attend an A&E department because it's best taken straight away. So it's more effective within the first few hours. And that's a point of intervention. Generally speaking, I have to say that's not the scenario. So people tend not to have had unprotected sex in the preceding 3 days. And then we can take time in terms of partner notification, unless, of course, somebody is partner is unwell, or if maybe they're pregnant or breastfeeding or something. Those are scenarios that you would be wanting to talk to your HIV clinic about. But as a GP, I think you'd leave that to the experts, really, in terms of how to handle that one.
So that 72 hours is a really interesting thing to hear, because actually there's a point at which we can intervene as general practitioners and know that time is a bit of the essence at that point.
Yeah, and also just to mention here that I know it's been covered in another podcast, but if there is somebody who has got HIV and their virus isn't suppressed, then their partners can take PrEP, which can help reduce the chance of them getting HIV, for example, if there was a condom break or something like that. And GPs might need to be involved with that. You might have both the couple as your patients, for example, and you might get questions from the other half, as it were. So just to be aware of that.
Yeah, so as you say, we're going to be exploring PrEP in a lot more detail in the next one of our podcasts, which I think is really interesting. There's lots of different corners to it. So people listening at home, please tune in for that. I think this idea of involving the partners within this sort of discussion is really important. One of the things that came to my mind was that this about confidentiality and who do you tell? I mean, who don't you tell? A little bit of a challenging one. Any thoughts around that?
So confidentiality is really tricky. The first thing is, most of the time, I would say, phone a friend. So get some advice. Most situations aren't emergency situations. It's better to take a step back, to gather the facts, and to talk to colleagues. So if somebody is on HIV treatment and they're taking it and their virus is suppressed, they're not going to transmit it to a sexual partner. So they don't actually have to tell their partners. So we do get a bit of questions around that. However, if they were with that person before they started treatment, so when they were first diagnosed, then that partner absolutely needs to be tested, because they might have HIV. In fact, they might be the person who gave it to them in the first place. We tend to really, as much as possible, try to encourage for the individual to tell their partner themselves, because it tends to go down much better that way. It's important to offer, very quick testing for the partner for HIV to sort of put their mind at rest and that sort of thing. But there are some scenarios when people feel they're not able to tell their partners. So maybe it's not actually a particularly long-term relationship, and they're worried that the person's going to just go and talk and expose them on social media, which unfortunately does happen. So you might consider provider referral. So there's we used to sort of in the older days sort of send letters and messages from other clinics, but now there's quite a neat sort of text messaging service where people can be texted to say that they've been in contact with HIV and they need to be tested. So there are ways around it, and that's definitely something that the HIV clinic will take on board. So it's not really something you need to do too much. I suppose the only scenario where that might be is if you've got a person in your clinic who and their partner, and they're both new to you, and you know that the partner's not fully aware and you're a little bit nervous about what's going on. And then I would really talk to the HIV clinic. And sometimes we need to speak to the legal team, but it's very, very rare, because the vast majority of times people will tell their partners. There have been situations in terms of sort of child protection. So it's very important to test the children of people who have HIV, because they might go many years without showing sort of signs of it. And obviously intervening with treatment early is very important. And sometimes we've had to have social services involved to make sure that children are tested. But this is something that's very generally is led on by the HIV service. And most of the time, it doesn't come to that, actually.
I think that is very helpful to hear, because I can imagine those are questions that might get brought up in a consultation in general practice, and I think for us to have some understanding of who we can speak to, some of the considerations around this, rather than the either rabbit in headlights, which we always dread, or telling people incorrect things, because of course, you know, stigma runs deep, including in health professionals, of course.
It's all whether somebody's putting somebody at risk or not. That's really where it comes around. And but most of the time, people want to, you know, they will tell their partners immediately, or once they've had a chance to digest the information themselves. And then you're just there to kind of provide the kind of emotional support and the support with testing and things like that.
I mean, I think this, if you're putting people at risk, is a really important thing, because one of the things that we're really hoping that we get through to people is this U equals U message. Grace, for those people that didn't listen to the first podcast, what do we mean by U equals U, and why is that so important for us as GPs to really get?
Yes, so U equals U stands for um, undetectable equals untransmittable. And what we mean by undetectable is when people are taking their antiviral medications and the viral load becomes so low within their blood that they're not detectable. And then that means that they're untransmittable, so they can't pass it on to their sexual partners. So this is, I mean, I guess if you're not working in the HIV space, this could be the first time that you're hearing this. And this is very exciting if you're hearing it for the first time. And so we want to make sure that the message is heard and also, I guess, believed by healthcare professionals and our communities.
Yeah, I mean, certainly, I suppose hearing it as a health professional and really internalizing that, because of course, different ways that we deliver information and the ways that we hold ourselves and the way that we are around our patients, all is going to contribute to the potential longevity of their care. And how much do you trust your doctor? How do you trust that they've got your best interests at heart and that what they're telling you is the correct thing?
Yeah, and the way that you say things as well makes such a difference. You know, even the way that you offer an HIV test. I think even like you said, we as healthcare professionals need to be mindful of the way that we say things to patients. Even for example, when we're asking them if they want to have an HIV test, just make it part of your routine blood testing um, spiel that you give to your patients. So I always just say, oh, we're just going to do your routine MOT blood test, including your blood sugars, your cholesterol, and we'll also do an HIV test if that's okay. And most of the time they say yes, absolutely. And when they say no for the HIV test, I just use that as an opportunity to educate them about HIV. And it doesn't really matter that they don't want the test, but at least we've had that conversation.
Wonderful. So I think so. We've made the diagnosis. We've contacted the HIV clinic. We have a patient that we've informed very nicely for this, and we've thought about some of the surrounding things. They come to the HIV clinic. Mel, what happens then?
We pretty much we check how they are, check that they're not unwell, because if they're unwell, we might have to see what diagnosis they might have, like if they had TB or something, and we might need to sort that out first. But if they're sort of generally okay, then actually we do sort of baseline blood tests, but we aim to start them on treatment fairly quickly. So maybe not on that first consultation, but probably on the second one, because we know that everyone does better on treatment, and it's important to get people's viral loads down, so that they are healthier, and also that they won't pass the virus on. Once they're stable on their treatment and their virus has come down to the levels that we've just talked about being undetectable, if they're fairly straightforward, they may only be seen every 6 to 12 months by the HIV clinic. So we're quite lucky in that we can do long prescriptions of 6 months long, and medications are also free. So that's quite an important thing to tell some patients, because they really worry about money and finances. Obviously, if people aren't taking their medications regularly, then we will see them a little bit more often. My sort of big thing in terms of involvement with primary care is drug interactions. So it used to be the case that very few patients would allow us to write to GPs, but now the norm is that we involve primary care in the care of our patients, because we're all part of the same team, and we're trying to reduce the stigma and trying to reduce the exceptionalization. But the other reason for this is actually that there were some really serious drug errors in the past. So one of the big ones, for example, is people who were on sort of ritonavir or cobicistat containing medications which are cytochrome P450 inhibitors. I don't know if you remember this from pharmacology
Oh
days.
gosh,
To a
yeah,
degree.
But
yeah.
there's quite a lot of drug interaction. So they're there in order to boost the levels of the HIV drugs, but they don't just boost the levels of the HIV drugs, and they can boost the levels of, for example, simvastatin quite massively. The other one that people always forget about is fluticasone, I think, because it's usually either a nasal spray or an inhaler. So my big thing is that as HIV clinicians, we make sure that the GPs know what somebody is on, and that the GPs do their side of things, or the pharmacists, and upload onto EMIS or whichever electronic patient record you're using to put the HIV drugs on there, and to just make sure when you're prescribing medications, including inhalers and nasal sprays, that there aren't any major drug interactions. There is a brilliant international, and it's in the UK website, which is www.hivdruginteractions.org.uk, which is run by the University of Liverpool. And that's basically what we use as our reference. I actually, now that everyone is becoming more internet savvy, it's a good app to tell patients about as well, because it's all about empowering people to manage their own conditions. So if somebody who's got HIV has that app, they can check for themselves that they're not being given something that they shouldn't.
Yeah, it's a fantastic website because it gives you all the evidence as well, backed of the different interactions. I use it. I use it all the time when I'm putting in medications on EMIS.
And I think, of course, putting medications in and thinking about the day-to-day healthcare of our patients with HIV is really important, because, of course, whilst you equals you, and understand that actually patients with HIV um, do very well once they're on the medication and are taking it regularly. There's of course all the other things that we need to think about in general practice, one of which is medication reviews and try to avoid these interactions, but lots of other things that we need to be considering day to day for long-term health. Grace, what should we be focusing on?
Well, whenever I see someone who is living with HIV, who's newly registered, let's say, or they suddenly, tell us that they are living with HIV, I always write down three things. The first thing is the clinic that they attend. So I document it, and I make sure that we've got up-to-date letters. And as Mel said, the clinic letters can vary, but it's usually once every six months. And if they don't have a letter, sometimes that can raise alarm bells, because they might not have been attending. So if they give me the name of the clinic and they're happy for me to contact the clinic to get the most recent letter, in case they're out of care. The second thing is I ask them what medications they are on. It is usually written on the clinic letter, but then I upload them onto our system, and I use EMIS, but I put them under the hospital prescribed system, and that makes sure that it can pick up on any interactions. So lastly, I ask them what their viral load is, because of course, if they're undetectable, they are untransmittable, and it means that they're taking their medications correctly. And I know that they're not at risk of developing any, severe infections. And so those are the sort of three main things that I make sure that I document. And then the other things that I check is if they're women or people with a cervix, I make sure that they're having annual smears, and they are eligible to have annual smears up to the age of 64. This can sometimes be a problem because the system might not pick up that they're eligible for a smear. So they might book in for a smear, and then the receptionist will say, "Oh, but you're not due a smear until 3 years time," and then they have to have an awkward conversation um, about the reason why they need another smear, and that can obviously be very difficult. But that's why it might be a good idea to put a note on the patient's records to say that they're due annual smears. And then the smear takers can make sure that when they request a smear, there is an option to say that the patient's living with HIV, so that they will get the annual letters as well for a smear reminder. And they also need yearly flu vaccines. They need the pneumococcal vaccine. And there are other sort of things that we can think about, but we are usually guided by the HIV clinic from the letters.
Hmm. And I think one of the things that jumps out to me is that thinking about the whole patient health is so important when we're dealing with patients with any long-term condition, but certainly with HIV. You mentioned the smears, which I think is probably going to be a surprise to quite a lot of a lot of GPs out there. But there's also some questions around CVD and cardiovascular risk, because I suppose if you've got a whole body condition, we've got to be thinking about the whole body. What would your advice be to people with respect to cardiovascular risk?
I'm gonna jump in here to answer that one. So we do know that people living with HIV are at increased risk of cardiovascular disease. It's quite difficult to tease out how much of that is HIV itself, how much perhaps is some of the older medications which may have had some sort of toxicities associated with them in the past. How much of that is because they're, as a cohort, for example, much more likely to smoke or suffer from sort of health inequalities and things like that. But as people live longer with HIV, and some people really have, near normal, if not better, life expectancies living with HIV, then we really do need to think about these factors. And there was quite an informative study recently. So we know, in the HIV clinics, we use QRisk-3 to calculate somebody's risk of cardiovascular disease. And we used to recommend a statin if their risk was over 10%. But there was a study that results came out about 18 months ago now, called the Reprieve study, and they looked at a large population of HIV adults over the age of 40 who had a Q risk that was lower than that, so lower than 10%. And they randomly assigned half of them to a statin and half not. And the statin that they used was, I can never say these, pitavastatin. And it's not one I'm familiar with, actually.
Nor us, actually. I'm not
Yeah.
sure about you, Grace. It's not one we use often.
No, it's one I think used abroad, but yeah.
Yeah, so that was the one that they used. They actually had to stop the study early because it wasn't ethical to continue not giving a statin to the patients who were receiving placebo. And that was because they found that the risk of major cardiovascular events was reduced by around 35% in those who were receiving the statin. I mean, in some ways, it was a bit of a shame that they couldn't carry on with the study, because we would have liked even more information from it. But very quickly, the British HIV Association has come out with guidance recommending that we have a discussion with all adults living with HIV over the age of 40 about whether they want to go on a statin or not. We're particularly targeting, however, because that's quite a lot of people, and a lot of people aren't really up for taking extra medications. They're not up for paying for medications, which a lot would at those kind of ages. We're particularly targeting those whose risk is above 5%. And so we're trying to have those conversations in secondary care. But obviously, statins are prescribed by primary care. So we're trying to improve the linkage up with primary care. The medicine we usually recommend is atorvastatin. If you're on sort of most of the treatment, then it's usually a starting dose of 20 milligrams. But if someone is taking a protease inhibitor, which can interact, then it's usually starting at 10 milligrams. And the HIV clinic should direct you. But we're very keen that GPs are open to this, because I don't think the information has properly got out in primary care that this is national recommended guidance. So we want everyone to know about it, and we need to get better at writing our letters and our action points to primary care.
Yeah, you're absolutely right. I mean, I think it would be news to a lot of us. It certainly was news to me that there was this level of risk and level of evidence to suggest to use that. So I think that's really powerful, and hopefully there's lots of people listening that will be able to think, actually, a few patients that might fall into that category. Let's look into it. So I suppose so we talked about that and looking at sort of whole patient care. I suppose the other place that GPs can really intervene very well here is to help people re-engage with clinics, particularly if there's, for whatever reason, that they may not be engaging any further. Can we outline the problem that we're having here? What tends to make people fall out of contact with their clinic?
So this is such a huge thing, to be honest, because we're actually getting very good at diagnosing the undiagnosed. I have to say, with sort of interventions in terms of ED departments, when you're pregnant, various screening, that's brilliant. Actually, in terms of people being unwell with HIV, it's increasing numbers of people who actually know that they're HIV positive, but they've stopped taking their treatment, they've stopped attending their clinic. And it's for lots of different reasons. So quite a diverse group. So some people will just be that actually they feel quite well. It's not a priority for them right now. They sort of missed their appointment, and then have missed their follow-up and just haven't got round to it. So there's that group who perhaps never were sick from HIV in the first place, and they've just got other things going on. There are people who have huge stigma around HIV, so they don't want their family members to see their medicines, they hide them from people. They maybe gave birth in a hospital and had people double gloving and treating them in a horrible way that made them sort of want to shy away from HIV. There are some who believe they've been cured, actually, that maybe have religious beliefs that they don't have it anymore. There are those who've got huge mental health problems, people with poverty, immigration, and then the other big sort of thing are drugs and alcohol, where people might be quite unwell from that and not engaging in care. And primary care is a brilliant place to re-engage people. So it's about secondary care alerting primary care that maybe the person isn't in care anymore, but that doesn't always happen because people access HIV clinics across the country. They don't necessarily go to their local clinic, so you may not have those ties. But it's about when you see somebody who comes in and for a routine appointment, just double checking that they're taking their medicines and they're okay, or perhaps thinking, so there was a very sad case that I dealt with during the pandemic, where it was a 35-year-old man who had been attending GP surgery for a year with recurrent oral thrush and kept being given, fluconazole and then like itraconazole even. And the GP, I think, thought that the gentleman was still taking HIV treatment, but actually he had dropped out of care some years previously, and he ended up dying. He delayed his presentation to A&E thinking he had COVID, which he didn't, and ended up dying from a really nasty cryptococcal infection, which is a yeast basically. That I felt could have been prevented if the HIV clinic had informed the GP that he wasn't taking treatment anymore, but also if the GPs that had been seeing had maybe asked a few more questions of the man, and even if he might well have said that he was taking treatment, but thought, hang on a second, this is a bit odd. I think we need independent backup for this.
And I think that GP gut feeling of there's something not quite right here, or actually what else is going on in your life, is so important, because we see patients, most frequently. Grace, I mean, from sort of your position as HIV champion in primary care, how can we do better? What sort of things can we do to help re-engage people and improve their overall HIV care and experience?
Well, yeah, I think what Mel said, reiterates the fact that primary care is such a great place for this, because we do deal with people who, for whatever reason, don't take their diabetes medications or their blood pressure tablets. And we've all got our sort of tricks or tips that we try and um, um, that we use to try and best support our patients. And I don't think HIV is too dissimilar in that way. Patients need to be able to build that relationship of trust with you. Maybe you need to follow them up a bit more regularly. But as Mel said, is also having that link with secondary care and making sure that we're getting those letters to say that the patient's out of care. So that is one of the things that I have been working on as GP champion, is to improve that communication between primary and secondary care. I mean, to follow on Mel's example, that is obviously what we're trying to avoid. But in an example that shows that how it could work, we were made aware of a patient who was living with HIV, who was seeing her GP with long bouts of diarrhea, and they weren't sure what was going on. But one of the GPs saw that they had a letter from the HIV clinic recently saying that the patient hadn't been in contact with them for the last year. So they were able to speak to the patient because they knew them, they'd known them quite well, had supported them recently through um, I think it was a bereavement, and so they had that conversation and raised. But because they had that letter, they were able to sort of um, start that conversation a bit more easily. And it turned out that that patient wasn't attending the clinic because they knew somebody from their local church who worked at the hospital. And they were worried that that person would see them going to the HIV clinic and then tell their community. So the GP was able to refer that patient to a different clinic, and the patient was very happy. And she's now back on treatment, which is sounds super easy, but it's completely life saving. And yeah, this is what we're hoping to be able to achieve going forward, just supporting our patients that we know well, and it's not just down to the HIV clinic.
And that's a wonderful thing to focus on, using those relationships and understanding that continuity of care that primary care does so well and is so important to help people re-engage with care, to help people understand from the very beginning, when we are broaching the subject of should we do some testing, to the delivering the news that they need to go and see at the HIV clinic, and then to continuing that care and all the way through their entire life. And I think that's just one of the wonderful things about primary care. So it's great that we can intervene there. Well, so I mean, we've covered a huge amount in these two podcasts. well, I just talked about it there, but we've covered a huge amount from the diagnosis all the way to the treatment. I'm so grateful to have had your time, Mel and Grace, around this really fascinating but super important topic. As we draw to a close with this, if you were to leave our listeners with any really key take-home messages or piece of advice, what would that be?
I think my take home message would be to encourage you within your practice to be more open about HIV and sign up to, educational events, teaching, and we'll put lots of things in the show notes that you can share with your practice, but not just your clinical teams, and also your non-clinical teams. So the people who are at the front desk who our patients meet when they first go into your practice, those are the key people to make sure that they feel comfortable talking about HIV. So yeah, I think that will be my message.
Wonderful. And coming to you, Mel.
And my thing, I mean, it's very difficult to come up with one, but I think a lot of people aren't aware of the U equals U message, the undetectable is untransmittable. And I'm really keen that we spread that message far and wide, so outside of the health sector as well. But I think it's huge in like combating stigma, because genuinely think if people stop, I mean, it's daft that people think that somebody having HIV might have an impact on them in some way, but if we really reduce that stigma and say that people who take their treatment properly cannot pass it on, then I think that will do an enormous amount in terms of us being able to be open and honest about HIV, and also for the individuals themselves to be able to tell their family and friends about their HIV. And if they're open about it, then I think their health outcomes are so much better and they can access the care that they need.
So thank you everybody for listening, and a big thank you again to my guests for joining me today. We've talked a lot about what happens after a positive result, why reframing the diagnosis matter, and how primary care can play a key role in supporting patients and reducing stigma. So join us next time where we'll be diving into PEP and PrEP, what they are, when to use them, and how they can fit into day-to-day practice. But until then, take care, and thanks again for being part of the conversation.